Parkinson Plus syndrome is a clinical syndrome which consists of a clinical feature of Parkinsonism along with additional neurodegenerative feature. So what are the features of Parkinsonism? It include tremor, rigidity, bradykinesia and the postural instability. And what will be the additional neurodegenerative feature in Parkinson Plus syndrome? It include dementia, hallucination, dysautonomia, myoclonus, gaze palsy and alien limb phenomena. So whenever a patient of a Parkinson disease present with these additional feature, it is called as a Parkinson plus syndrome. There are a wide variety of a Parkinson plus syndrome, but pathophysiologically it is divided into two types, the synucleinopathy and the tau nucleopathy. In synucleinopathy, there is an accumulation of protein alpha synuclein and other protein inclusion in different part of brain. The synucleinopathy consists of Lewy body dementia and multisystem atrophy, previously called as a Scheidegger syndrome. Now come toward the tau nucleopathy. In tau nucleopathy, there is an accumulation of tau protein in different part of a brain which lead to the Parkinson plus syndrome. The tau protein is also called as a neurofibrillary tangles. It is produced when the cytoskeleton get abnormally phosphorylated, and in the tau nucleopathy include the progressive supranuclear palsy and corticobasal degeneration. Now let's discuss each type of a Parkinson plus syndrome briefly. The first one is a Lewy body dementia. In Lewy body dementia, the dementia is a predominant symptom characterized by the deficit in attention and cognition. Other than this, the patient will also have a visual hallucination, rapid eye movement and a sleep behavior disorder. Remember that in Parkinson disease, the dementia is also a late feature. So how we will differentiate the Lewy body dementia from the Parkinson disease dementia? So we have a simple rule for it. If the dementia is the initial or the presenting feature within the 1 year of the movement disorder, it is called as a Lewy body dementia. But if a dementia develop after 1 year of the movement disorder, it is called as a Parkinson disease with dementia. To treat the Lewy body dementia, we have to treat the symptom. If a patient have a cognitive impairment, we can use a cholinesterase inhibitor or the memantine. If a patient have a movement disorder, we can use a L-DOPA, and for the rapid eye movement sleep, we can use a melatonin or the clonazepam. The second one is multisystem atrophy, previously called as Scheidegger syndrome. Clinically, the multisystem atrophy is divided into two types, the MSA with predominant Parkinsonism and MSA with the predominant cerebellar ataxia. The predominant Parkinsonism MSA consists of bradykinesia, postural instability, rigidity and jerky pulse along with the action tremor, while the MSA with the predominant cerebellar ataxia is characterized by gait and limb ataxia along with dysarthria and eye movement disturbance. In both of these types, there will be a autonomic disturbance. The first autonomic disturbance in multisystem atrophy is erectile dysfunction. After that, the patient can also experience urinary frequency and incontinence, while the late presentation of autonomic dysfunction is postural hypotension. To treat MSA, the levodopa are not used. For the rigidity or the dystonias, we can use a botulinum toxin, and for the orthostatic hypotension, we use a fludrocortisone acetate or the midodrine. Remember that do not use a levodopa in orthostatic hypertension in Parkinson disease, because the levodopa itself causes hypotension, and in multisystem atrophy the patient has a postural hypotension, so it will worsen the condition. Always use a fludrocortisone acetate for the orthostatic hypotension in multisystem atrophy. After MSA, the third Parkinson plus syndrome is corticobasal degeneration. In corticobasal degeneration, there will be an asymmetrical movement disorder affecting one limb initially. Later on, there will be an extreme rigidity, focal myoclonus, dystonia, and the alien limb phenomena. The alien limb phenomena is an involuntary irregular movement of a limb. You guys can see the alien limb phenomena in this video. To treat the corticobasal degeneration, we can use a botulinum toxin which will improve the function of a muscle. It will relieve the contraction. And for the myoclonus, we can use a clonazepam. The clonazepam is a drug of choice for the myoclonus. While for the cognitive impairment, which usually occur in a corticobasal degeneration, we can use an acetylcholinesterase inhibitor, the donepezil and the rivastigmine. It was all about the corticobasal degeneration. Now come toward the last Parkinson Plus syndrome, the progressive supranuclear palsy. The progressive supranuclear palsy have wide variety of phenotype. The most common and the classic form is Richardson syndrome. In Richardson syndrome, the patient will initially present with gait dysfunction which lead to the frequent fall. Other than this, the supranuclear palsy is a hallmark for Richardson syndrome. So what happened in supranuclear palsy? Supranuclear palsy, the patient will lose ability to move eyes vertically, focus eyes on an object, and there will be a loss of control of eyelid movement. Other than this, the patient of the Richardson syndrome will have a extended posture, which is opposite to the flex posture in a Parkinson disease. So it is a differentiating point for the progressive supranuclear palsy. On radiographic examination, the Richardson syndrome will show the hummingbird or the penguin silhouette sign on MRI. This is produced due to the midbrain atrophy while the pons are reserved. You guys can see the hummingbird sign on this MRI. To treat the Richardson syndrome, we usually give a symptomatic treatment. For eye abnormality, we can use a mirror prism lens. Along with that, we can use an artificial tear which will lubricate the eye. So it was all about the Parkinson Plus syndrome. If there is still any question, you guys can ask and stay tuned for more update.